Hematology, oncology, pathology, leukemias. So before we start leukemias, I just want to do one quick overview of what it means again to be a leukemia. It's unregulated growth and differentiation of white blood cells, right? So if we have a neoplasm of white blood cells in the bone marrow, it's going to be defined as a leukemia, okay? This can lead to bone marrow failure, and then what we're going to be seeing is pancytopenia, potentially. So we can see anemia due to the decrease in red blood cells. We can see an increase in infection risk due to the fact that we have a decrease in the number of mature white blood cells, even though on the CBC, we might see an elevated white blood cell count. It doesn't take into account the amount of functional white blood cells or mature white blood cells, right? Because we know that leukemias, once again, is unregulated growth and differentiation of white blood cells, but those are not functional white blood cells. So even though our CBC might show elevated white blood cells, we still have an increased risk of infection because those white blood cells aren't working well enough. And then lastly, we have an increased risk of hemorrhage due to the fact that we have a decrease in platelets. So this is all known as pancytopenia, a decrease in all functional red blood cells, white blood cells, and platelets, okay? Now, there are two separate types of leukemias that we need to discuss. There's the lymphoid neoplasms, and then there's the myeloid neoplasms. We already discussed that hematopoietic stem cells can differentiate into two different lineages, the lymphoid lineages and the myeloid lineages. And the lymphoid lineages give rise to our T cells, our B cells, and our natural killer cells, whereas our myeloid lineage gives rise to our red blood cells, as well as our neutrophils, basophils, all those granulocytes, and then monocytes, right? And all other things like that. So that's the initial differentiation that we like to make between the lymphoid lineage and the myeloid lineage. So let's begin with the lymphoid neoplasms. So this is going to be our cancers involving our B cells and T cells, right? So the first one that we're going to be talking about is acute lymphoblastic leukemia, so ALL. Now, what we need to know about ALL is that it's most frequently occurring in children. This is going to be pretty much a dead giveaway for majority of the questions that you're going to be answering for any ALL question. If you see that it's a child that has presentation that's similar to cancer or like leukemia, it's most likely, most of the time, going to be ALL. Now, don't automatically put ALL. Make sure that the full picture is present and before you put the ALL answer. But most of the time, it's really, really helpful to see that that it is a child with ALL. Okay. Now, there's two types of ALL. It could be T cell ALL or B cell ALL. And the way that we can differentiate those things is through markers. And so for T cell ALL, it's just going to be mainly presenting as a mediastinal mass, okay? And so this can look like SVC syndrome, which we'll discuss later on in respiratory. But what you need to know is that if it's a mediastinal mass in a young child, then the most likely answer is going to be TALL, okay? So T cell ALL. And all of our T cell ALLs have the markers that are mostly associated with lower numbers. So it'll be like CD2 to CD8 positive. So 2, 3, 4, 5, 6, 7, 8. Those are all our TALL markers. For BALL markers, we're going to be looking at the rounder numbers. So that's how I remember it. So it'll be CD10, CD19, and CD20. So both 10 and 20 have a 0 in it, just like how B has a 0 in it, and a ball, BALL stands for ball, so it's like circular. And then the 9 has a little 0 in it as well for CD19. So CD10, CD19, and CD20 for BALL. And another way that people remember that is just BALL has the larger number markers, okay? For all ALLs, we're going to see a TDT positive, and that's an important aspect for it. All you need to know is that it's TDT. You don't really need to know what that means. And the most likely metastasis is towards the CNS or the testes. That is something that they like to ask on. Lastly, the translocation for 1221 is indicative of ALL, as well as translocation 922, which is the Philadelphia chromosome, which has a worse prognosis compared to the translocation 1221, okay? Now, translocation 922 for ALL isn't that high yield or highly associated for step 1. We'll see the Philadelphia chromosome associated with something else later on, okay? Next is chronic lymphocytic leukemia or small lymphocytic lymphoma, which is CLL or SLL. And this is for patients that are of older age. Now, that's not going to be as good of a giveaway because we're going to see AML and CML also are seen in older age patients. So, I mean, just keep that on the differential, but don't automatically use it as something to just get rid of everything else. So CLL and SLL, both the same thing, most likely seen in elderly people. And the markers are very helpful. We're going to have CD20 positive, CD23 positive, as well as CD5. It's very odd to see CD5 positive for CLL or any type of those lymphocytes. But since it's there, you have to be able to denote it. Okay, so CD5, CD20, and CD23. There really is not much else of importance except for the fact that you're going to see smudge cells on peripheral blood smear, okay? So make sure you understand what a smudge cell looks like on peripheral blood smear, and it would be a dead giveaway. They named it perfectly because honestly it looks exactly like just like a smudge on a sheet of paper, but it's very helpful to know that CLL presents with peripheral blood smear showing smudge cells, okay? Lastly, of the lymphoid neoplasms is hairy cell leukemia. There's very little that you need to know about hairy cell leukemia, okay? The first thing, they named it once again, really helpful for us. Since it's called hairy cell leukemia, it literally looks like there's hair coming off the cells. So if you see like fuzzy appearance around the cell, make sure you look up the histology of hairy cell leukemia in the peripheral blood smear. You'll see how hairy the cells look, and then automatically you could pick hairy cell leukemia. It stains TRAP positive, and this is one of the main things that you have to know about hairy cell leukemia because not many other things stain TRAP positive. So make sure you understand that it's TRAP positive. It also presents with massive splenomegaly and a dry bone tap. So if the patients come in to try to get a bone tap, they will have a dry tap on aspiration, okay? Those are our 3 lymphoid neoplasms associated with the leukemias, okay? Next is the myeloid neoplasm. So now this is on the other side of the spectrum. We're not talking about our T cells or our B cells. We're mainly talking about now our myeloid cells. So I'm talking about the granulocytes, right? So be aware of the differences in that. So the first thing that we're going to be discussing is AML, acute myelogenous leukemia, okay? So AML. Once again, median onset age is like 65 years old, so still older, okay? So we're not going to see a young patient unless it's ALL most of the time. I mean, don't 100% put it if you see a young patient, but make sure you're keeping an eye on the age. So AML is going to be an older patient with our rods. I cannot tell you how important our rods is. Like there is no other thing that is as important as our rods. It will show up on every single one of your exams. It's so important. Make sure you understand what it looks like. Make sure to look for it. Even if there's one present, you know that you're dealing with AML, okay? Because our rods are specific to AML. So even if you see one and the presentation is completely different, let's say it's a young person and there's an our rod, who cares? You're not putting ALL because it's a young person. You're putting AML because there's an our rod. Okay, so don't get confused. Stick with the pertinent positives. If you see an our rod, it's going to be AML. Okay, and all the our rods are that they are myeloperoxidase positive cytoplasmic inclusions. Okay, so they're MPO positive. That's another thing that they like to test on. Our rods are MPO positive. All right, now there's a subset of AML called APL, and our rods are a lot more seen in APL. Okay, so once again, if you see our rods, your answer is going to be APL or AML. They're not going to trick you by putting both of those as answer choices, okay? Now, what do we need to understand, okay? At the end of the day, for AML, if I see our rods on histology, once again, look that up, and MPO positive, then I'm thinking about AML. Now, specifically for APL, what I need to know is that the patient is going to have a translocation of 1517. Now, this is specific for APL, right? This is a type of AML. APL has a translocation 1517, okay? And that is a translocation involving all trans retinoic acid, which is just vitamin A. So anytime you see vitamin A, retinoic acid, something like that involving cancer, you know that you're dealing with AML. And so sometimes we treat the patients with vitamin A, okay? So really important to keep that in mind for APL, that it's translocation 1517 and it involves vitamin A, trans retinoic acid. Lastly, it can progress into DIC. So as we discussed, disseminated intravascular coagulation is massively associated with AML, specifically APL. So if you see a patient that has a presentation similar to APL and they're asking about a potential cancer or leukemia, start thinking about your APL, start thinking about your translocation 1517, start thinking about AML and our rods, all right? Lastly is our CML, chronic myelogenous leukemia, okay? Now, this is highly associated with the Philadelphia chromosome, translocation 922. Now, you're probably wondering what the hell the Philadelphia chromosome is. At the end of the day, it's translocation of 922, and the genes are BCR-ABL, BCR-ABL, okay? And they love to ask a question about this. So any CML question, they're going to ask, hopefully, Philadelphia chromosome, translocation chromosome 922, BCR-ABL, boom, automatically, CML, okay? Now, there's multiple things that we can use to treat these things, but specifically for BCR-ABL, we're going to use a tyrosine kinase inhibitor known as imatinib, and we're going to talk more about that in the pharmaceutical section, but just understand that imatinib is going to be used for our Philadelphia chromosome type leukemias. Lastly, CML is the only one that we're going to see a rise in basophils, although it's a small, low-yield thing that they don't really hone in on. If you see a CBC with an increase in basophils and there's no parasite infection in sight, and they're talking about something that's involving leukemias, the answer will most likely be CML. All right? So just an overview, because leukemias are very important. ALL can be separated into BALL or TALL. TALL are going to have the smaller CDs, so 2 to 8, whereas BALL are going to have the larger ones, 10, 19, and 20. They're going to be both TDT positive, and they are most likely to spread to the CNS and testes. And the TALL most likely presents with a mediastinal mass. CLL and SLL, this is going to be in older patients. It's going to be CD20 positive, CD23 positive, and CD5 positive, and the peripheral blood smear is going to show smudge cells. Hairy cell leukemia is going to be TRAP positive, okay? Very important. You're going to have a dry tap on aspiration of the bone marrow because you get marrow fibrosis, and you're going to have massive splenomegaly associated with that, okay? And they're going to have that fuzzy appearance when you have histology. Moving on to the myeloid neoplasms, you have AML. No, don't forget the specific type of AML is APL, which has our rods that are MPO positive, and you're going to have a translocation of 1517 for APL that involves retinoic acid of vitamin A. DIC is a highly associated pathology with AML and APL. Lastly is our CML. If you see a patient with translocation 922 BCR-ABL genes, then you know you are most likely dealing with the Philadelphia chromosome of CML, and you can provide imatinib, which is a tyrosine kinase inhibitor. Lastly, if you see a rise in basophils that's not associated with any parasites, then we know that we're going to be maybe looking at CML.